All right, sorry about that, guys. My computer crashed. My browser crashed and froze when I tried to load, or Virtual Classroom tried to load the PowerPoint, so we'll throw it on YouTube. So pulses of the upper extremity, this stuff you should be pretty familiar with, so it should be pretty easy for you. This program, just like GIGU and CVPP, I built them from scratch with Bates and Seidel. These are Board of Chiropractic Examiner books. They're on the reference list. Where do board questions come from? From these two books. Where do they don't come from? Jarvis. Why does the school use Jarvis? I have no idea. But my job is to get you to do well on boards, so we need to use the board books. Pulses, and we are going to run into some differences than the way you've been taught. I'm teaching you strictly the way that the board reference books say. All right, pulses. So, of course, created by the left heart, right? During systole, it shoots a blast of blood up the ascending aorta, and it goes throughout the body, and you can feel a pulse. Sometimes there's a jugular pulse, a venous pulse, but you can never palpate a venous pulse. You can look at it, but you can't palpate it because the veins are too squishy. So we'll look at how you're supposed to take pulse. That is how you're supposed to take a pulse, by the way, not the way that you guys do it. Let's see. So why are you taking a pulse anyway? What's the purpose of that? Well, there's three things you're looking for: the rate, the rhythm, and the amplitude. The rate is how fast is the pulse going. You can take a pulse, and you guys, that's part of your CCP exam, right? You got to be able to figure out how fast the heart is going. It should be about anywhere from 60 to under 100 beats. Usually it's around 80 beats per minute. The rhythm, normally it's like it goes pulse, 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 pulse. That's not always true, though. We'll learn about pulsus paradoxus, and if a patient has that, when they breathe in, the pulse stops. When they breathe out, the pulse comes back. If they have heart palpitations, the pulse can be pulse, 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 pulse. It can be all over the place. So the rhythm's supposed to be steady. It's not always steady. The amplitude is just if you take your own pulse, you've probably done that before. It should be a flicker, like a little flicker into your finger. It shouldn't be pounding like you just ran around the school 5 times. And we'll talk about this called a bounding pulse. This is from Seidel. There is a pulse rating scale. A 2 is normal. A 3 or 4 is too much. 1 is weak. 0 is no pulse at all. And that's from both Bates and Seidel. You should know that. What causes a 4 bounding pulse? So those are hyperkinetic states. So what causes this guy right here? Those are bounding pulses or hyperkinetic states. Well, obviously exercise, running around the school. Wet berry, which we're not going to see in this country. Fear, anxiety, major fear, anxiety. But the big ones I want you to know is anemia. So anemia, you have a decreased hematocrit, decreased red blood cells, and the heart throws the blood around like nothing. The heart doesn't have much mass, or the blood doesn't have much mass, so the heart can grab that blood and just whip it out through the ascending aorta. So you get a very powerful pulse in people who have anemia or hyperthyroidism, aka thyroid toxicosis. So that can do the same thing. Both those increase cardiac output, especially anemia, because of the decreased viscosity of the blood. What can cause a bounding pulse? We'll talk about this several times. It's so important. Something called aortic insufficiency, or also known as aortic valve regurgitation. And that occurs after systole. Remember, we have a diastole, and because of the elastic recoil of the aorta, the blood drives backwards, and it shuts the semilunar valves, mainly the aortic valve. If you have something wrong with your aortic valve, it's been damaged by scarlet fever or rheumatic fever, or just getting old. Sometimes they start to get lax. The blood can gush back into the heart, and that's not a good thing, because this chamber is supposed to be relatively empty at the end of systole, and now it's got quite a bit of blood in it, And now here comes your atrial systole, and the bottom line is you overfill your ventricle on every single systolic beat. And you know the deal with Frank Starling's law, or Starling's law. If the heart is overstuffed with blood, it's going to contract more powerfully. And that's exactly what happens. You get a huge blast of blood out. It even can affect your jugular, your carotid arteries. And then it's cut short diastole. During diastole, you get this huge leaking of blood backwards. So that wrecks your heart if you don't have something done about that. You can't last more than 6 months to a year or so with a severe aortic regurgitation. You have to have the valve replaced, or your heart will be ruined and you'll be up S's Creek. All right. The people with this condition, aortic insufficiency, where blood blasts out of here, it can make the carotid artery bug out like crazy, like bulge out, and then quickly disappear. As systole is exacerbated, the blood just drains out really quickly. It's a real phenomenon. You can see it, and it has a word or name. It's called a water hammer pulse, aka Corrigan pulse, aka collapsing pulse. And that's something you have to watch for. You watch people's, we're going to learn how to auscultate, and you already know how, but we'll teach you again how to auscultate and palpate the carotid arteries, the carotid pulse. And you have to watch that with your eyeballs to make sure it's not bulging out like crazy, because that's going to be a water hammer pulse, and it indicates aortic regurgitation. Here's a video you can go to and watch where this fairly young guy has aortic regurgitation, and that's during every systolic beat. His carotid artery bugs out like crazy, and then it sucks back into nothing. So that's a good example. There's a couple YouTube videos on that. What about, so if you're kind of off topic a little, but if you're taking pulses and you have a decreased pulse, what's the difference between a unilateral decreased pulse and a bilateral decreased pulse? What does it mean? Well, you have to think of your anatomy and all those veins and arteries, especially the arteries. You have to think of the road maps, the arteries. So if there's a beaver dam in one artery, let's say your brachial artery, the beaver dam will cause downstream. It'll affect the blood going downstream. Does that say upstream? Yes. That's okay. A unilateral change means the beaver dam is somewhere upstream. So let me continue with my demonstration. So if the brachial artery gets compressed in the biceps somewhere and beaver dammed, so there's not a lot of blood flow, your radial and your ulnar artery are going to be, you're going to have weak pulses there in both of those. If the beaver dam is only in the radial artery, like the proximal radial artery, let's say right after it splits from the brachial artery, then your radial artery is going to be way low, the pulse, but the ulnar artery is going to be fine. So you can kind of deduce where the beaver dam is I guess what I'm trying to say. And what about a weak and thready pulse that you really can't feel? Well, you have to make sure it's not normal. If the room is really cold, that can do it. If the patient is really nervous and sympathetics are turned on, that can also make a weak and thready pulse. But if it's really, really ridiculously weak, like you can't even feel it, there are some conditions in that in older people, the number one you think of is a decrease in cardiac output from heart failure, cardiomyopathy. If the pump's not pumping blood out very powerful or very forcefully, you're not going to feel a pulse. You would also expect the blood pressure to be quite low in these conditions as well. Same with if you have a beaver dam in the aortic valve, blood can't get out of the heart. And so the same thing, anything that decreases cardiac output can cause this problem. If you have PAD, peripheral artery disease, we'll talk a lot about that in the lecture, but that's atherosclerosis, severe of the abdominal aorta, and it almost completely close off the abdominal aorta. So all the lower extremity pulses will be absent. Not absent, they'll be really, really decreased. Well, they might be absent if it completely closes. But those are conditions that can cause any beaver dam obstructing the lumen of blood, the blood flow through the lumen will do that trick there. just a note about taking blood pressure. There's a little trick I like to tell you. Usually I would have you for in class. I can't see you now, but you can all do this. Take your left finger, your index and middle finger, and just palpate the radial pulse. It should be right by the styloid process of the radius. And if you pull just medial to that, and it should be lateral to your extensor carpi ulnar or radialis tendon. So it should be right in there. And if you palpate really light, you might be able to find it. Let's say if you can't find it, or even if you can find it, do this trick and see what happens. Push your fingers down really hard and hold it for like 3 seconds, 5 seconds. And now slowly let the pressure off. And I'm doing it right now. And I feel 2, 3 huge squirts of blood. So that's a good way to find pulses if you can't find a pulse. You can push down. And what that does, it creates a beaver dam. And the blood and the pressure back up upstream, up the radial artery. And when you let the pressure off slowly, the blood squirts through the constricted artery. And you can feel that rapid blood flow with your finger pads. So that's called the compress and release trick. Let's talk about some specific arteries. I'm not sure if you know how to do the superficial temporal, but we'll talk about it. Remember that from Gross 1 and Gross 2 anatomy. It's right in front of the tragus of the ear usually. So if you take your 2 finger pads, kind of like a rabbit ears in a way, and palpate it. Put your finger pads right here and right here. You can all take a second to do that and see if you can find it. Some people actually have to go up here where it splits into a temporal and a parietal branch. You might have to poke around up here, but most people can feel it somewhere around the TMJ. And that's a good one because there is a condition that loves that artery we'll talk about here in a second. Okay, and you can use the squishing technique if you want. So what's the deal? Why am I introducing the superficial temporal artery to you? There is a disease called temporal arteritis. That it's an autoimmune disease. It's the #1 cause of vasculitis. And it's an autoimmune attack against the tunica intima and tunica media of an artery. And for whatever reason, it absolutely loves the superficial temporal artery. But unfortunately, second place is the ophthalmic artery. And the inflammation can be so bad that it can cause a beaver dam and severely decrease flow through that artery. And so if it happens to the temporal artery, well, you're going to have pain. It's not going to be the end of the world. But if it happens to your ophthalmic artery, you can go blind from this. And it is a real, it's out there. So you should know about that. Another word, the AKAs, excuse me, temporal arteritis. It used to be called giant cell arteritis. That still might be on boards. Superficial temporal arteritis, giant cell temporal arteritis, or Horton's arteritis is the guy who discovered it. So a lot of AKAs for that one. But it is the most common vasculitis. So autoimmune attack, usually the superficial temporal artery, but it's not only the superficial temporal artery. And because, as I said, it likes #2, the ophthalmic artery, #3, the coronary artery, #4, the vertebral artery. These are, you don't want inflammations, and these are critical arteries. So you have to be really careful with them. And the patient will come in complaining of TMJ pain. This artery, when it starts getting inflamed, you can start getting blood clots in the artery. And you can sometimes visibly see it. And so they'll come and say, oh, my jaw hurts. And you look and you palpate this artery and there's no pulse. And they're really sore. And so that's exactly what it is. So the clinical signs are headaches, TMJ pain around the TMJ. They might have a fever if the infection is bad enough. Blurred vision is a bad sign. Amaurosis Fugax, I want you to memorize that word. It's like a buzzword. It's like dusky red and Amaurosis Fugax. I want you to memorize those words, and we'll get to dusky red next week. But yeah, but the most common one is just pain when you palpate the superficial temporal artery. These patients are usually over 50, 72 is the most common age. And again, two of the key signs is a painful superficial temporal artery, sometimes with palpable cords, which are just blood clots in there. And then maybe you can't even feel a pulse there when you can feel a pulse on the other side. So watch out for this one. Amaurosis Fugax, that's the way it's pronounced. It's called shade-drawn blindness. And what happens if this autoimmune attack, this inflammation affects the ophthalmic artery, you'll start to go blind. And the blindness is gradual and it has a specific pattern. And people who have had it said it's like somebody pulled a shade, you know, those dark blackout shades you can pull down. Somebody pulled a blackout shade right down, and sometimes it comes back, sometimes it never comes back. Had an ER doc from Stanford talk to us about that one quarter, and it usually doesn't come back once the Amaurosis Fugax phenomenon is there. That's it. If you want to make the diagnosis, you just take a biopsy, take a piece out of there. Doing erythrocyte sedimentation rate is always going to be raised up. So that's a sign of inflammation. Patient might have an anemia, but big one is you can take a biopsy of it. Here's a drawing of it. So there's temporal arteritis, and those are cords, those are blood clots. That's a beaver dam from the inflammation. And so the patient doesn't know. He thinks it's TMJ. He's got it on YouTube, and it's not. All right, brachial artery. So, I mean, I put all the details in. These are my teaching slides. If somebody ever had to fill in for me, they can read these. So you know a lot of this stuff. The brachial artery, you guys don't know where to take the brachial artery, though. The brachial artery, it runs medial to the bicep tendon. So there's the tendon of the bicep, and there's the aponeurosa of the bicep. It's right between that little split is the best place to palpate it. And if the cubital fossa runs, teres major runs this way, and that's the crack of the elbow. That's called the cubital crease. This whole thing is called the cubital fossa, or the anti-cubital fossa is another AK for it. And so how do you palpate the brachial artery according to the board books? Even Jarvis says to do it like this. In the crack of the elbow, you find the bicep tendon and slip your fingers off medially. And if you all do that, and here's the trick though, don't do it yet. So find your bicep tendon, slip your fingers off medially, and now here's the trick. Straighten your elbow all the way out. You don't hurt it, you don't have to jam it, but just straighten your elbow and now push down. I mean, mine is just pounding right there. Why is it pounding there? Because you're trapping it against the condyle of the humerus. It has nowhere to go, so it's really easy to compress it. If you try to poke your fingers up, which you guys do all the time, and don't get me started on that. We've tried to get the people who teach that to stop teaching it, and academic freedom. They can teach what they want. That is not the place to find it, because there's nothing to trap the artery against. If the person has really big biceps, you might be able to trap it there, but the chances of you finding it there aren't great. The chances of you finding it just medial to the bicep tendon are great. And so that's where I want you to find it. If I ask you to palpate the brachial artery, you better not stick your fingers up here in the bicep or you'll get points off. Okay? Let's see. So that's enough said about that. There's an example of exactly, you can see the crack in my the cubital crease right there. That's where it is on me. My bicep would be right about here. Some of you, it might be here, but it's somewhere in here is where you can find it. You can use that push and release trick to find it as well. So I go on rambling and rambling about that. There's another view of it, how the cubital crease would be right about through here. And you can see how nice it is right on the other side of the bicep, the medial side of the bicep. Medial is here. Radial artery, you guys pretty much know this one. I just already said this. It's just medial or toward ulnarly speaking, but anatomically it would be medial to the styloid process, laterally to flexor carpi radialis. And it's commonly used for heart catheter procedures now. They used to go through your femoral artery, which causes blood clots, so big blood clots. Now they go through your radial artery, and it's a lot better. There's only about 6% of the time you're still going to get a blood clot. But notice if you get a blood clot, if they use this to draw blood or to put a catheter in to go up to kind of thread it all the way up to your heart, if you get a blood clot and it gets stuck here, it's not going to kill your hand, because your ulnar artery also supplies a superficial and a deep palmar arch. So your muscles might be a little upset, especially your thumb, but you're not going to destroy your whole hand. So there's a test that we're going to learn called the Allen's test. That tests the patency of this ulnar artery as well as the radial artery. But you should never, ever, ever have a radial catheter procedure. Not even a blood draw. Nothing should be stuck up there unless you do the Allen test to make darn sure that your hand has a double blood supply. In some people, their ulnar artery goes like this. It doesn't connect to the palmar arches. So if you get a blood clot in this artery, you're in big trouble. You're going to lose a huge piece of your hand. So that's, you guys are too young for that now, but try to remember that. And they'll do, because they'll get sued if they don't do that. So they're pretty good at doing it. The two-finger style, Bates and Seidel both say this is the proper way to take a pulse. You don't want to wrap your hands around and take a pulse, which is what you do, I know. But that's not the way. I wouldn't do it like that if I was going to boards, because that's not the way the board books say to do it. All right, and then we know the squirting technique. We already talked about that. Make sure that the wrist is flexed, or make sure that the wrist is an extension, not an extension when you do this. That'll decrease your chances of finding it. You should not do it like this, right? That's from Jarvis. Jarvis is not a board book, and this is not the way to do it. Most of the books say to do it like that. You got a much better, that's the rabbit ears I was talking about, much better chance of palpating. Ulnar artery is usually a little tougher to find, so there's the rabbit ear approach. So just do the best you can. Special testing. So Allen's, now I used to have modified Allen's. I just took it out this quarter because the new Bates 2020 came out and they got rid of it. Because there was a modified Allen's test and an Allen's test. And they're the same. The only difference was the Allen's test is a two-part test. You're going to test the ulnar artery, then you're going to test the radial artery. You have to do the test twice. The modified Allen's test, you only test the ulnar artery. So I took that out. I think that's getting a little too crazy. So we're just going to teach you the Bates, the Allen's test according with Bates. Okay, so this is a really simple principle. And the specificity of this test is 97%. So if this test is positive, you definitely have some circulatory problem, either a blood clot. If they have pain in their hand, it's probably a blood clot. If they don't have any pain and the test is positive, they probably have that weird ulnar artery that doesn't connect to the superficial arch. The radial artery almost always makes up the superficial and deep palmar arches. This ulnar artery can be anomalous though. So let's look at the test. Everything I just said about it, it's a two-part test. The reason you want to do this, you want to make sure the ulnar artery, if they stick a needle in the radial artery here, you want to make sure that there's still supply to the superficial and deep ulnar arches, because coronary angiography procedures and angioplasty procedures all go up through the radial artery. So you better make sure there's a backup. And this just to show you that even if they do this procedure, there's a 6% chance you'll get a clot formed here. A thrombosis will form and it'll get stuck here and somewhere down here. So it'll mess up this arch. But if you still have the ulnar artery, that's okay, because you'll still get good blood flow going through here. But if you don't, if you have an anomalous ulnar artery that just goes down to here, you're in big trouble. You should never have anything stuck in that artery. Okay, 6% chance of developing a clot. Okay, so here's the test. So you can all, well, you can't really do this. You'd have to do this on a partner. And I'll link a YouTube video to demonstrate this. But you open and close the hand several times. You don't have to have your hand up in the air. I don't know where some people are sticking their hands up in the air for gravity. You don't need to do that. If you just squeeze your hand twice, that's enough to squeeze all the blood out of it. So squeeze it and hold the fist. Your patient is doing this. Patient is squeezing, holding a fist tight. No blood can get into the hand when it's so tight. Doctor is coming around and pushing the pads of the thumb down at the level of the styloid processes here. Pushing down, not poking down, not with the tip of your thumb, with the pad, the soft pad of your thumb. You're clamping down hard, and that's not letting any blood out. So by the patient making a fist, he or she has driven the blood out, and when you clamp down, you're not letting blood back in. Now you have the patient open up their hand while you're still clamping. And just to make sure you did it right, the hand should be all gross white and green and blue looking because it's ischemic. When the hand is open and you're sure that there's no blood in there, just take your thumb off there and let the blood flow. If the ulnar artery is supplying the palmar arches, within 5 seconds the palm will turn rosy red. It'll go back to its normal color. If it doesn't go back to its normal color, then that's an indication that you have an anomalous ulnar artery. If there's pain, if they have pain in their hand and you do this, maybe there's a blood clot somewhere upstream or somewhere downstream, so that you can also test for anomalous artery or you can test for a blood clot. So I need to take that. I've tried to take these out of there. But Allen's test. So have them open their hand. That's just what I said. And we're testing the ulnar artery. This one's remaining closed, right? Because if you open that, the test is ruined, because then the blood can get down. We don't know what the problem is. Keep this one closed. So we're testing to see if the ulnar artery will circulate and make the hand happy again with blood flow. All right? And then part 2 of the test, you just repeat it. Only the next time you keep the ulnar artery pinched off and you open the radial artery and make sure the radial artery has good flow. Got it? It's pretty simple. Normal result, the hand should turn nice rosy red here within 5 seconds. Repeat it on the other side, just like I said. All right? If it is positive, if it doesn't come back within 5 seconds and you're not super nervous and the room is not freezing cold, you should not have any type of catheter procedure. They're going to have to go through your femoral artery. And one more test, I think you know this one, it's really simple. Capillary refill test. You just pinch the back of the patient's finger until it blanches, turns white, and then let it go. And the color under the nail will come back within a couple seconds normally. 2 seconds, that color could return. So you're testing the capillaries and the arteries of the hand, the finger's hand, and anything upstream from that too. Let's say that you pinch down on the little finger, and when you let it go, it takes 15 seconds for it to turn rosy red again. It stays white for a long time. But you do the thumb, and it comes back really quick. Well, then you suspect there might be a problem with the ulnar artery. So you work your way up. Now you can take the pulse of the ulnar artery to see if it's there. You can also do the Allen's test and test that ulnar artery to see if there's blood flow. If there is, you can go up. Well, the brachial should be working, right? Because the brachial splits into the radial and ulnar. So see how you can kind of be a detective and figure that stuff out. A positive if it fails to fill within 2 seconds, and it means there's a beaver dam somewhere upstream. If all the fingers are really sluggish to fill, it's probably heart failure or something wrong, some major beaver dam with the heart or aortic stenosis. So you can kind of, if it's just one area and they have pain in their hand, it could be a blood clot. So it's a good way to see if the pipes are clogged somewhere. And then confounders, what's that mean, confounders? That means the test results are messed up. If the examination room is freezing cold, it may take 10 seconds. And in lab, when we were doing this for real, and it was really cold outside and the room was cold, it did. Quite a few people, it took like 7, 10, 15 seconds. So that's a big confounder there. You have to have a normal temperature room. Cigarette smoking is known to decrease blood flow. So yep, that's that. They might be a smoker, and that would be normal for them. It's not good though. Anemia, peripheral edema, things like that can mess the test up. All right, so that's the end of this lecture. So I guess I'll shut this one down. That's right, I was going to go talk to you. You guys aren't here. I'm just doing these by myself. So let's shut this down. And let's discard these.